have Dr. Amol Palekar. Amol Patil. He is professor of pharmacology. And today we are going to discuss about research questions, but we will also restrict ourselves to a little bit of tuberculosis.
Okay.
We will discuss about tuberculosis and questions pertaining to tuberculosis.
That's great, ma'am. That's great.
Yeah. So first we'll have a case presentation, and Amit is going to present a case, which we actually had in the morning on CPC. And Amit, you can start with the question.
Sure.
Please, Pandita, please put the case. PPT. So we have, can you hear? Hello, can you hear, all hear us? Okay. So there is a case which was presented today, CPC, and the case is related to a 42-year-old male. There is no previous comorbidities, and it was presented like fever from 10 days. It's low-grade fever, 2 to 3 spikes at 100 degree Fahrenheit, blood in stools 10 days, loss of appetite, vomiting 3 to 4 times per day, and decreased urine output for 2 days. Next slide. So this is the hemogram which during the admission time. Admission was outside on 2nd January 2020, and when he was admitted, the hemogram was 12.4, and it is decreasing gradually. The TLC is increasing. TLC was increasing. DLC, the platelets count are decreasing. And these are the biochemical analysis, and the coagulation profile. Dr. Ishant, can you please elaborate?
So, these were the investigations of the patient done at the time of admission and subsequently during the stay of the patient in the hospital. So at admission the hemogram was 12.4, but it decreased. It showed a decreasing trend from 12.4 to on the 18th it was 5.6. And the total leukocyte count at the time of admission was 3100, and they also subsequently decreased to 900, and then they started showing some increasing trend with the dip on 14th. The differential leukocyte count was also showing the increasing trend since admission, but and the platelets showed a decreasing trend since admission to the end to the 11th. They decreased to 22,000, and then they started showing a increasing trend. Coming to the biochemistry, the sodium and potassium, the electrolytes were not available at admission, but on the 5th there was a hyponatremic picture. The patient had increasing creatinine levels, and even in the coagulogram there was the PT was increased on 5th.
Dr. Nishant, you can tell the relevant investigations because all these counts and all don't have that much of relevance here. So basically, in this patient, as he was intubated and they tried to take a tracheal aspirate, that came positive for gene expert for tuberculosis.
Yes.
So the question here was whether this patient had tuberculosis or not, because the AFP did not come positive anywhere in the culture from any site which was positive mycobacterium tuberculosis. So the question which was there was how accurate is gene expert in predicting the diagnosis or in making the diagnosis of tuberculosis. So today we have Dr. Amol with us who will discuss about the research questions, and then we will see whether we can apply the same concepts to framing of research questions as we have from this case. So, Dr. Amol.
Thank you, ma'am. Good afternoon, everyone. Is the audio, video, the presentation clear to everyone? Okay. So we are here to discuss over the next 45 minutes or so about the study designs relevant for the research questions. You come across a lot of research questions when you are seeing your daily routine practice, but it depends entirely upon the investigator, how far the investigator can go into the population, how much facilities are there with the researcher or the investigator, okay, how much time they can put in the research, okay, whether it has to cut short or whether it has to be a long follow-up study, okay, or whether there are sophisticated facilities available with investigator to measure a particular biomarker or correlate a biomarker with a treatment outcome or the morbidity or any toxicity parameter, okay. So we are going to discuss study designs, how we select a particular study design. What is a study design? It is a specific plan or a part of protocol you mention, okay, for answering a particular research questions, okay, that allow you to translate your hypothesis into an operational one, okay, that gives you much clarity to ethics committee or the reviewer members even after you develop that particular research into a manuscript later on, okay. So everything, a step-by-step approach is mentioned for answering a particular research question, okay. So study design is a general aspect or a particular section of your study protocol that comes after deciding your aims and objectives. What is our time of follow-up you can give that decides your objectives, okay. What is your aim of the study, what question you are going to answer that, okay. And based upon your study design, your output variables will be depending upon which you will be compiling later on and analyzing and applying stats over there and deriving the inferences, okay. So study design is an integral part of your research or study protocol, okay. As I mentioned earlier, you can go forward, you can go backward, you can have a prospective evaluation, you can have a retrospective evaluation, okay. You have to decide the direction of the study, okay. let us say in your daily routine practice, you come across a fluoroquinolone gatifloxacin showing a hypoglycemic features. Okay, how do you answer that one? You are able to hear me? Imagine a hypothetical scenario. You have a commonly used fluoroquinolone, imagine ofloxacin, and you are suspicious about the hypoglycemic tendency of the drug. How you are going to evaluate this? Okay, so it depends upon study design. If it is a retrospective one, you take all those patients, their previous lab reports, if the patients or if the record history is available with them, okay, or if the fasting or postprandial blood sugar or any sort of that data is available, or you can do a interventional one. You can give them in a controlled setting a gatifloxacin and follow them up to a certain time point where what is likely to have a pancreatic effect, what is likely to have an effect on islet cells, and that can culminate into the glycemic changes. Okay, so you can have a retrospective or a prospective design or a combined one. Okay, so it entirely depends upon whether you are going to have some kind of intervention for your research or no. If there is no intervention, active intervention is not happening, and you are just planning to have a observational study, then you have to first decide upon your comparator arms. Okay, whether you are going to have a comparison between the two arms or you are not having a comparison. If you are not having any kind of comparison, okay, then it just becomes a descriptive study. Okay, you estimate the percentage of exposure, you estimate the percentage of risk, and you can have some kind of association from the descriptive study. Okay, like a cross-sectional one. Okay, you go into a population at particular time point and you evaluate prevalence of a particular disease or particular exposure, or suppose a corona epidemic is going on. Okay, so you can go into a general public hospital emergencies and what are the viral fevers or the subtype corona that the patients are coming up with. Okay, so it may not derive you kind of any association or a correlation or a causation, but it may give you a brief idea about the prevalence, what is going on in particular population, in particular geographical area, or like that. Okay. On other hand, if you have certain comparator arms, like one getting a gatifloxacin, one not having a gatifloxacin, and you want to evaluate both the groups, okay, in a retrospective manner or in a prospective manner, if you are carrying the two groups, okay, then it can become a cohort study if it is a proper forward follow-up study. Okay, it can be taken as a case control study, or it can remain as a cross-sectional one. Okay, as I mentioned, if you are doing any intervention particularly, okay, or a controlled setting you are having, like you are taking care of their diet chart to minimize the food drug interaction, then if you are doing a randomization, then it will increase the quality of evidence. Okay, you may be knowing the levels of the evidence based pyramid. Okay, if the randomized control trial, it has a higher value. Okay, if it is a non-randomized control trial like prazosine, if you all remember, prazosine became a drug of choice for a scorpion bite. Okay, as a treatment. Why it became? Because just an intern student, when went into a rural posting, saw that the cardiovascular benefits of all type of antihypertensives when compared in a simple non-randomized way. Okay, the investigator just allocated certain section of population to each antihypertensive and saw that the pulmonary hypertension component and the other cardiovascular components were very well taken care of, mortality significantly reduced with prazosin, and that's how a non-randomized clinical trial also can generate a best level of evidence. Okay, but every time this may not be a situation, and a randomized controlled trial which doesn't keep a specific pattern of drug allocation or specific pattern of follow-up or outcome evaluation, keeps a study unbiased, okay, without any conflict. Okay, so that gives you a best kind of evidence. So this is a brief idea about today's presentation, how a study design is selected as per your research question. Okay, going through the observational studies, as I mentioned earlier, it can be a simple descriptive studies, okay, or it can be analytical one, cross-sectional one, okay, cohort study, okay, just an observation of a particular outcome, whether it is a treatment related toxicity or treatment related efficacy that is happening with the treatment allocated or no. Okay, experimental one, I will come upon this, whether it can be kept as a non-randomized clinical trial or a randomized or a crossover design or a field trial or a lab trial. Okay, so first we take a descriptive. Descriptive studies involve 3 subsections. Okay, if the investigator is able to go into population, imagine mumps virus, measles, mumps, rubella vaccine is given to us particular school population. Whatever number of children are there in a particular school, they are vaccinated with MMR vaccine, and you are just want to evaluate the autism prevalence. Okay, then you can deduce some kind of association out of descriptive, but not a causality. Okay, not a correlation. It is a simple type of association you can hypothesize based upon the descriptive studies. You can also have a series of cases, like I mentioned, if I have a suspicion that fluoroquinolones have some kind of impact on a pancreatic function, I may take into consideration the variety of pancreatic damage that is happening with the fluoroquinolones. Okay, whether it is a pseudocyst development, whether it is a pancreatitis development, pancreatitis development, or whether it is a simple hypoglycemia, hyperglycemia development, or whether I can consider insulin resistance markers, okay, evaluation or like that. So you can have a group of cases, okay, you can take into consideration exposed to a particular etiology, okay, and variety of outcome you can discuss with the case series pattern. Okay, the descriptive study also have a small subsection of case reports. Case reports gives you an opportunity to discuss a particular type of presentation. It may be rare, it may not be. Okay, you may do a certain genetic or a particular biomarker evaluation or kind of any specific investigation not done prior in particularly answering that particular case. Okay, imagine a tuberculosis patient, you are regularly relying upon chest x-ray, sputum examination, gene expert, and tomorrow you come up with a certain another type of suppose amikacin resistance test you want to see. Okay, so you can write a case report of that also, you can include that in the case series also. Okay, in that way you can present your descriptive data. Okay, so descriptive data is generally data that is presented in a percentage format. I'll just show you one example. This is a study of antidepressant change. Okay, if there is a disease that is all right, I'll skip this, don't worry. Let's stick to presentation. Okay, imagine that you are seeing a particular disease that may have a significant section of non-responders, treatment non-responder, resistance you can say, or a progressive disorder you can say. Just going at one particular time point and evaluating how many cases are going towards resistance or a non-responder section, okay, that kind of data in particular geographic section or a ethnic section, okay, with available resources in the form of investigation, the treatment, okay, that can give you a descriptive data, okay. It also matters what kind of descriptive data is coming from the different part of the globe, okay, because when you follow a particular treatment guideline may not be applicable to a different part of the world, okay. So you can generate a hypothesis out of a descriptive data, and it can give you some kind of association, need not be a causation or correlation. What is the benefit of doing a descriptive study? It's easy to do, okay. You can do it any time point, okay. When I say one time point, you are doing this descriptive study, meaning it need not be a one day, it may not be 1 week, it can be a 1 month, okay. You are going to the outpatient clinic, and over a period of month, what is a non-responder, what are the progressive cases that are going from treatment to first line treatment to a resistant level, okay. So it is good for generating the hypothesis, but as I said earlier, you can quickly finish off this study in a month span, okay, but there remains a bias or a patient selection bias, I can say, okay, and your data is not being compared, okay. So since it does not have a control arm, okay, so it just for developing a hypothesis. Then coming to analytical observational studies, okay, you can have a cross-sectional study design, you can have a case control and cohort study design, okay. In a cross-sectional, as I mentioned earlier, a single time point data is collected and you develop a data on prevalence. I gave you example of MMR vaccine and autism in a school scenario. That is just one example. You can develop, okay, an association, okay. So coming to a cross-sectional study design, you can classify your study population in exposed to MMR vaccine, not exposed to MMR vaccine. Out of vaccinated children, you can have those developing autism spectrum disorder, not developing autism spectrum disorder. Likewise, you can do in a non-vaccinated group, and you take this numerics or the variables in the 2 by 2 factorial design table, okay, and you can have a simple value of prevalence ratio you can calculate for that particular population, geographic population, okay. So I am giving you a little homework today. If you can just take down these values, okay, out of a population of 1000, if imagine a hypothetical one, 100 people are doing meditation regularly, okay, and out of that only 2 are having diabetes, remaining 900 were not doing meditation at all. Out of that 220 are having diabetes, okay. Can you build a 2 by 2 factorial table and tell me what is the prevalence is having, okay, of diabetic population in people doing meditation, okay. This is you can do later on, okay. Coming to again a cross-sectional, it is a quick, cheaper method of doing research, okay, but the weakness is it cannot establish the causality, okay, causality to the drug treatment, causality to the drug side effect or whatever, okay. So coming to a case control study, you are having a particular set of population, it may be a patient population or a general population, okay, and you want to follow them back, what happened in the past, what was the exposure that is having, okay, that can be any, that whether that can have any association with the current disease under study or whether it does not have any kind of association. So it is a look back study, and here you can evaluate the exposure, okay. So case control study, a biggest obstacle, not an obstacle, but biggest test is selecting a controlled population for a case control study. Okay, because if you are not able to select the controlled population, then there can be a confounding which can happen and which can have an effect on your variable study variables. Okay, so it depends upon association of the control with the variability and the effect. Okay, the final effects you want to evaluate. So choosing the control population is the biggest task in a case control study. Okay, as I mentioned earlier, you can have a diabetic population and non-diabetic population, and you can ask them whether they were doing a meditation or an exercise or a particular type of exposure, like particular vaccine that is the population had after birth. Okay, you can go back and you can check that. So it is a outcome disease correlation with the exposure. It is a kind of retrospective study also is another name for that. It also gives you a association, not the causality. Here the variable that you calculate is a odds ratio. Okay, you infer your, or you make some conclusions based upon your odds ratio. When the odds ratio is 1, that means there is no association between exposure and the outcome. Okay, when it is more than 1, then there can be some association, okay, that you deduce out of it. Okay, I have given you a sample scenario of a case control study of autism spectrum disorder patient, whether they were vaccinated or not. Okay, so going ahead with the case control study, you can answer the rare diseases, rare disorder, but not the tuberculosis like diseases. Okay, you will examine the relationship between the exposure or the disease and a particular exposure. Okay, it can also be helping you in generating the hypothesis. It is also a type of fast study. You can wind it up in a month or so. Okay, it is a cheap, no particular resources are required. Okay, the cost effective study, I would say, but it just gives you a odds ratio. Okay, a smallest type of evidence in evidence based medicine pyramid. Okay, there are a lot of weaknesses that you can have in a case control study. Okay, it cannot measure the incidence, it cannot measure the prevalence, it cannot measure the relative risk associated with particular type of exposure. Okay, and you can only study one particular outcome. Like I mentioned, number of diabetic people doing meditation in the past. Okay, and non-diabetic people, you can have a hypertension people. Okay, you can select your control arm. Okay, but there is a selection bias, how you select your study participant. Okay, or a patient population. Another type of study design is a cohort study design, where you begin with exposure. Okay, or you begin with a disease-free individual. You classify your patient as exposed to a particular etiology, environment, or the treatment, or not exposed to a particular treatment. Okay, you follow them up for a certain time point, like 3 months follow-up, 6 months follow-up, and based upon your follow-up, you decide your secondary endpoints. What is a primary and secondary endpoint, guys? The primary endpoints are the endpoints that decides your sample size. Okay, secondary endpoints, you keep it up for supporting your primary endpoint as easy endpoints or a small endpoints, like what is the cost of the treatment in the both the arms. Okay, what are the side effects happening in the both the arms. Okay, you can keep all cause mortality as your primary endpoint. Okay, so that is the difference in primary and secondary endpoint. Sample size based upon primary endpoint. Okay, are you with me, guys? Okay, so So you record your outcomes over a time of follow-up, what you have in both the arms. You can have a multiple arms also. Study arms can be 2 or multiple, okay? And you calculate your outcome or a relative risk. It is a better type of statistics as compared to odds ratio, okay? Relative risk. Yes, ma'am. Yes, ma'am.
So, as Dr. Amol has been talking to you, we are into different type of study designs, and as you can see, as he has given you a lot of examples also, that different type of study designs are made to answer different type of study questions, research questions. So, taking some examples, for example, if we have, say, tuberculosis, we take disease as tuberculosis, and then we see, let's take an example of prevalence of tuberculosis. So we may say that we want to know what is the prevalence of tuberculosis in children who are exposed to adults with TB. So that will be, conducting a kind of observational study in which one would like to see out of the total population, which is children, and ones which are exposed to patients with, say, adult patients with tuberculosis, what is the difference in prevalence of tuberculosis in these patients? So this kind of study will be done either as a case control study in which you will have cases, that means children who are exposed to TB and children who are not exposed to TB. And then you try to find as to whether rate of infection or rate of disease is higher in patients who are exposed to tuberculosis. Then second type of questions can be like a cohort study. Cohort study in which persons, which are sharing common characteristics, and you want to know how they are doing over a period of time. For example, again, we can take some patients, say, tubercular meningitis. There are, say, about 1,000 patients who have suffered from tubercular meningitis, and we are following them up over a period of time. And many times these patients have complications like hydrocephalus, or they may have drug-related side effects, or they may have devastation of the disease. For example, they may have hemiplegia or monoparesis or any other neurological deficits. So we are following up these cohorts, and then we want to see as to what are the factors, or whether these patients are remaining the same or they are changing over a period of time, because their exposure has occurred, and now we want to know whether there is any intervention which can change their scenario. For example, sometimes we give these patients anti-inflammatory therapy, and we want to see if these patients will do better on that. Then once the disease is there and treatment has been completed, one would also like to see if there is any effect of physiotherapy on that. For example, if you want to have these patients who have monoparesis, hemiparesis, they would need some kind of physiotherapy to have an improved kind of quality of life. So these are the examples which we are taking from the disease tuberculosis, and as I had discussed earlier, we would be addressing some of these questions which are coming in the field of TB. Then we can have some interventions, like you will be talking about interventions later on. So yes, we can carry on.
Thank you, ma'am. So as ma'am said rightly, okay, cohort study can begin in between disease, like you have a diagnosis of tuberculous meningitis and you want to follow them up, whether they are taking 9 months to show the remission, or whether they are progressing to resistant cases, or they are developing treatment related toxicities or mortal all-cause. I mean, you can answer a lot of questions depending upon your primary and secondary endpoint and the time you have taken for the following up. Okay. So prospective, you have to have a sufficient time in your hand for having a cohort study. Okay. It is a controlled design. You observe the patient or study participant over a period of time. So it is a controlled setting, a sort of controlled setting, not like as rigid as that of RCT. Okay. But it can help you in determining the incidence of disease as well as identifying the factors associated with the treatment outcome. Okay. Since it involves a lot of time and lot of follow-up, so it may be sometimes expensive. Okay. And it may be difficult to carry out because you have to have a surety that in your absence, somebody is looking after the study conduct. Okay, so you have to identify your geographically defined group, that suppose a high hilly region group, okay, whether they are having a protection for tuberculosis, okay, because of weather environment there also, okay, and then you can have your comparator arms. You have to decide those who are not exposed to that kind of environment, and you can follow them up over a period of say years, okay, and then you record your variables, that how many are developing tuberculosis in the hilly areas and how many are developing in the plain areas, and you can deduce your inferences. Small abstract I have taken from the PubMed. Okay, it is just a comparison of ductate therapy versus cryotherapy for common warts. Okay, and here the investigators are deducing an inference that out of 51 patients completing the study, 26 were treated with ductate therapy, 25 with the cryotherapy. Okay, 85% with the ductate therapy versus 60% with the cryotherapy showed a complete resolution. So ductate therapy is obviously a conclusion, which is a better arm in comparison of the two. Okay, what is your inference out of this abstract which I have taken from PubMed? What is your idea whether these conclusions can be generalized to all population? Okay, you have to look into the population also, like this is a military population, okay, whether they have a certain kind of exposure which may not be there in a other population, and whether the age of the population that is same as your patient age group, okay, that also matters, okay, which you should be looking for. Okay, when you are having a cohort study, okay, you are having certain free hand of showing your inferences, like your absolute risk reduction. You can show the incidence of the disease happening in a particularly factor or the environment, like I mentioned earlier. Okay, incidence of tuberculosis in a hilly area minus plain areas. Okay, so you can have disease happening in particular exposed type, disease happening in non-exposed type, and you can deduce your variables, and you can have a variety of ways you can present your data. Okay, like relative risk is general term that is mentioned here. If we go back a little and just try to calculate a relative risk, okay, what is the relative risk here? 85% resolution with the ductate therapy and 60% with the cryotherapy. Okay, that is a simple data presented to you in a published research. 85 minus 60 divided by 60 into 100 will give you a relative risk calculation. Okay, that may exacerbate the difference. Actual difference is exacerbated sometimes. Okay, if you calculate this 85 minus 60, okay, divided by 60 into 100, okay, that gives you 42% difference. Okay, 42% difference for a ductate therapy preferring over a commonly available cryotherapy. So what statistical variable or a parameter you use to show your data that will have a much impact on a generalizability? Okay, like I mentioned, relative risk is sometimes amplify the difference. Mind my words. Relative risk may amplify the difference in the two study arm, but absolute risk reduction gives you the exact difference in the two. Like 85 minus 60, there is only 25% difference in the two. 25% difference is shown by absolute risk reduction. Okay, the refined version of statistics, a better version of presenting your data, so that the people taking the meaning out of your research is number needed to treat and number needed to harm. How do we calculate number needed to treat? It is by formula 1 upon absolute risk reduction. If it is a vaccine trial, number needed to harm. When the number needed to treat is less than 10, less than 5, it is better. Okay. For this abstract I presented, number needed to treat comes 4. Okay. So it is a better treatment. Okay. Ducted therapy over a cryotherapy. Okay. So weakness of cohort studies is what? It is expensive, time consuming, and you can not answer the rare outcome. You have to go with the common diseases like diabetes, hypertension, tuberculosis, follow them up. You should not have attrition in the follow-up. Sufficient number of sample size has to be attained over a period of time. Okay. There can involve a confounding factor on part of investigator, on part of patient, on part of disease also. Okay, that has to be tackled. Or you can have a subgroup analysis when you prepare a final manuscript. Okay, you can have subgroup analysis and see the distribution of confounders in the two. Okay, coming to experimental study design. Okay, it is considered as a gold standard in a evidence-based medicine pyramid. You see the randomized control trial with a lesser number of false positive, lesser number of false negative value, creating a large, best kind of evidence. Okay, so clinical trials are always taken as a gold standard for determining the causality, establishing association of particular outcome with the particular exposure. You can answer your question in a randomized control trial. Randomization is another topic which can itself take a day long. Okay, there are a lot of ways you can randomize your patients. Okay, so there are permuted block randomization, that is a simple to perform. You can take a help from the Microsoft Excel. You can generate the code for sufficiently long number of patients. Okay, over and above a plant size. Okay, and you can allocate the patient to particular code that is given. Okay, that is decided. Okay, you can have a parallel arm studies. Okay, concurrent parallel design. You can keep your control arm as a historical control from already published study, or you can have a control arm for a fresh recruitment in the study itself. Okay, you can have a sequential RCT design. You have a period, you have a intervention for period 1, period 2, period 3. Okay, you can have an external control in your RCT, like I mentioned, historical control. Okay, nowadays to cut short the price, cut short the expenditure on the study design, investigators are taking help from the historical control arm. Okay, provided the follow-up, provided the evaluation, investigations are matching with your study outcome. Okay, so there can be non-randomized control trial. I gave an example of prazosin. Okay, prazosin decreasing mortality in a scorpion bite patient, which is a common scenario in the rural areas. Okay, all right. So as per construction of your study design, you may create a simple study design parallel arm, or you may have a crossover study design where you decide the time period 1, time period 2. You have 2 arms who will be exposed to study medication, who will be exposed to a standard of care. Okay, you can go into the field and you can have intervention there. Okay, like you give a MMR vaccine in a particular school population and follow them up whether they are having a sufficient protection over a period of time, whether they are developing a certain side effects or diseases. You can say autism like. Okay, you can create a small follow-up study in a lab setting where you can control the exposure. Okay, exposure to some kind of dye. Okay, some kind of routine chemical that is used in the lab. Okay, whether it is a carcinogenic, whether it is developing some kind of dermatological disorder over a period of time, you can develop data accordingly. Okay, so quality is decided by your randomization, whether you keep a simple toss a coin and you allocate the patient to a study arm A and B. If that is a way of randomization, then there is a 50% bias in the patient allocation. If you decide a permuted block of 4, then also there is a 25% bias when you come to a 4th patient or 8th patient or a 12th patient, because when the 3 patients are allocated, definitely in a block what is remaining is a 4th one. So there is a 25% chance that you may have in a patient allocation. So there are always ways and design how you keep your block size variable, how it decreases your bias, how it decreases the chance finding. You can keep single blind, double blind, triple blind. Okay, you can keep your assessor also blind, the statistician. Okay, there are ways when the investigator has a communication and not exposing, not letting the assessor know that which is an exposure arm out of many. Okay, so you can have a crossover study design in a chronic diseases. Okay, chronic diseases like epilepsy. You cannot have a crossover study design for acute illnesses. Imagine a myocardial infarction patient comes, okay, and receive a treatment in emergency. Okay, can you have a follow-up of the patient with 2 type of treatment with a washout period? No. But epilepsy is a chronic illness where you may put a patient on one anti-epileptic, then have a washout period, then put on another anti-epileptic or another therapy. Okay. Likewise, chronic illnesses can be answered through crossover study designs. Okay. Clinical trial is a generally comparative study. Okay. You do intervention and you follow them up over a period of time. Okay. If you don't have a control arm, then it will not be a RCT. At least a historical control help should be taken, I would say. Okay. If you are able to recruit fresh control group, well and good. But to cut down the expenses, you can take a help from historical control. Okay. This is a small example how you have a RCT design. Like you have a sufficiently large patient group. Okay. And you have a study group A, study group B. Okay. Then you have a sufficiently long washout period. Okay. This is an example of crossover study design. Okay. You have to have a washout period. What is a washout period, guys? Can anybody explain me washout period? Imagine you want to compare 2 anti-epileptic in a epilepsy children or epilepsy population, and you are opting for a crossover design. So you will have a particular anti-epileptic, let us say levetiracetam versus lamotrigine. Okay. After a sufficient length of 1 follow-up, we call it as a period 1. Period 1. We give them a washout of 5 half-life. You understand 5 half-life of a drug? You understand 5 half-life of a drug? Okay. So that is a minimum washout period that has to be given. And then you can change the treatment arm. Here, the participant itself stands as a control. Are you getting me? If a same person is receiving 2 type of treatment over a period of time, the control is a self person, okay, over a period of time, right? So you have this kind of study design called as crossover study design. It can only help in a chronic illnesses, not in the acute one. Okay. Then there are certain study design like Quincy experimental study design when you have 2 type of group. Just finishing, ma'am. So out of many groups, you are just comparing the 2 groups. one receiving intervention, not receiving intervention, following them for outcome of interest, develop or not develop, okay, or having any negative outcome like that. If you have not many groups, like group 1, 2 and 3, more than 2, then it is called as block experimental study, okay. You can decide your outcome parameters and accordingly you can evaluate the risk or the benefit in the particular group. Okay. All right. So we'll conclude this session and we'll take some questions from the audience. Yes, sir. Dr. Kaustubh.
Yeah, actually, I have two questions. The first question is a quick one. Sir, you included cross-sectional studies within analytical studies, but don't they also qualify as descriptive studies?
Okay.
One.
Say descriptive. Say if you are analyzing a particular biomarker in a particular disease. Sorry, ma'am. Sorry. So if you are evaluating a particular biomarker, okay, in a disease group, it is also taken as an analytical descriptive study. Okay, let us say autism spectrum disorder patients, and you want to evaluate their TNF alpha levels in the plasma. Okay, so you are analyzing a particular biomarker in them. Okay, it is also a type of one-time cross-sectional study where a simple biomarker is being evaluated. So it can fall in the both observational as analytical.
Okay, I have one more question. It's about carrying forward the example that Minu Madam gave. Say my research question is to determine whether childhood tuberculosis is associated with having a contact history of adults suffering from tuberculosis. That is my research question. Now, aren't there two ways by which we can proceed? Say scenario one would be we would take cases of children with tuberculosis and controls with children without tuberculosis, and we'll ask in both the groups, we'll try to seek out how many in each group had exposure to adults with tuberculosis. That is scenario one. The second scenario would be we take cases which comprise adults with tuberculosis and controls which are adults without tuberculosis, and then we try to seek out how many of the children who were in contact with them had tuberculosis. Like out of these two scenarios, which one would be the better one to proceed with?
The one that you mentioned later on, because that's a prospective one. Because in that you have a case of tuberculosis, and then you are prospectively following up, or you are investigating the context of that particular patient. For example, the second one is like you have an adult with tuberculosis, and then you investigate the childhood contacts of that particular patient. So that's a better study design because that gives you direct information. Whereas the one in which you have children, where you're just asking a retrospective history, whether or not there was a contact with tuberculosis, that is an indirect one, because at that time you don't have the proof that the person who was in contact with the patient actually had tuberculosis or not. So these are some of the advantages which you have of prospective studies over retrospective studies. Because the second example, the one in which you're starting with children is actually a retrospective. It's a historical fact which you are looking at. So to my mind, I think the first design would be the design in which you're following the adult patients would be a better one in comparison to the one in which you are just taking a history from the children. Contact.
Dr. Devashish also have a question.
Dr. Devashish has a question?
Yes.
Can I add to ma'am's statement?
Yeah, Amol wants to add something.
Like ma'am said, adult exposure and the children's developing TB, a prospective design gives you idea about calculating relative risk, absolute risk reduction, number needed to treat, all sophisticated statistics you can apply to betterment of the evidence generation. Okay, so as compared to case control, always a prospective study design is better.
So there's a question by Dr. Devashish, and the question is washout period receiving intervention with anti-epileptic drug efficacy? You're absolutely right that while you are giving an anti-epileptic, you will not, test the same patients without an anti-epileptic.
It will be answered. Yes.
So you're right. So, but there are certain situations in which you can give a drug and you can take off a drug and then see whether its effect is totally washed out first, and then you maybe give them a control intervention, as may happen in some of the conditions in which taking off the drug is not that detrimental.
It will be studied only as an add-on design, not as a taking out the anti-epileptic. It will not be like that. It will be add-on design.
Then, time needed to eliminate a drug from the body, nearly 5 half-lives.
Yes,
right?
yes.
Okay. Alright. That is from Dr. Kamal. Okay. Dr. Kamal, any other question or comment about today's presentation?
No, ma'am. It's okay, ma'am.
So I think we need to, when we are losing some of our previous participants, so I think we do expect that in our further sessions we will have more people. And we will concentrate on case presentations. So today, did Kaustav have a case? Somebody had a case presentation to do today?
Ma'am, I had a research question, and it was kept for the next week.
Okay, all right. So we will do it next week. Okay, so if there are no more questions, we would like to thank Dr. Amol.
Yes.
You want to say something?
Now we have next session on 11th March.
So next session is on 11th March. And what's the topic?
Topic is
So we'll inform you about this session, which will be next week. And I think it will be on, again, about PICO and...
yeah, it is on source of bias in various study design and prioritization.
Okay, so sources of bias in different study design. So maybe, this bias which is there in retrospective studies can be discussed over there. So with that, we come to an end. I'd like to thank Dr. Amol and all of you for participating. Thank you very much.
Thank you.
So